Good afternoon, everyone, and a very warm welcome for today's special Med Talk CME, organized on the occasion of World Retina Day. I am Ada, your moderator for this program. Our session today is titled Blurred Vision Clear Solution, a panel on common retinal conditions. Retina related disorders remain one of the leading causes of visual impairment, but timely diagnosis and advances in treatment can make a significant difference. This panel discussion brings together eminent experts to share their knowledge, insights, and clinical experience in tackling common retinal challenges. It is my privilege to introduce our moderator for today's session, Dr. Arti Mohan. She is a highly skilled retinal surgeon at Rajan Eye Care Hospital in Chennai. She has been actively involved in advanced surgical and clinical management of retinal diseases. With her expertise, she will be guiding today's discussion and steering valuable conversation between our great panelists. Dr. Aarti, it's an honor to have you with us today. I now invite you to take the session forwards and introduce our esteemed panelists, ma'am. Over to you. Thank you.
A very good evening to one and all. At the outset, I'd like to thank IJCP Group for giving us this opportunity to be speaking on common retinal pathologies in association with systemic diseases today in conjunction with the World Retina Day. Without much ado, I would like to invite the first speaker, Dr. Deepthi. She is a medical retina consultant working here at with us at Rajan Eye Care. She is experienced in handling all sorts of medical retinal diseases, lasers, and intravitreal injections. Today, she will be giving us an overview on management of diabetic retinopathy and the various challenges associated with it. On to you, Deepthi. Deepthi, you're not audible.
Uploading my PPT here.
Yeah, yeah. Now you're audible.
Yeah. Okay.
So while Dr. Deepthi is uploading her presentation, we'd like to emphasize today's session. We would like to emphasize the importance of screening the retina in majority of systemic diseases. So, as the common saying goes, eye is the window to the body. So, by examining the eye and the retina, it gives us a lot of clues to what is happening to the systemic health of the patient. Sometimes the ophthalmologist or the retinologist is the first physician who picks up that something is systemically wrong in a patient, especially in a patient who presents with bilateral disc edema, and then we order for an MRI and we find out a space occupying lesion, and then we refer the patient to a neurologist. There have also been conditions where patients just refer to us with blurred vision. We examine the eye and we find them to have diabetic retinopathy, and then refer the patient to the diabetologist or the physician, after which the patient is diabetic treatment is initiated. So the ophthalmologist is at oftentimes the the physician who picks up a lot of things which are wrong systemically. This also goes vice versa in a patient with a lot of systemic diseases or long-standing systemic diseases like diabetes and hypertension. They are found to have the reflection of these diseases in the eye, which is typically picked up in the retina, so which need attention and care for re-establishing the vision of the patient. So normally in all these mentioned scenarios, we work in conjunction with the physician to optimize the systemic health of the patient, and then to treat the ophthalmic part. And today I also have immense pleasure in inviting our HOD and Chief Vitreoretinal Surgeon, Dr. Supriya Davir, who will specifically be talking about retinopathy of prematurity, its screening and management. So, Madam has more than 20 years of experience in handling pediatric retinal disorders, especially retinopathy of prematurity. Following Dr. Deepthi, Madam will be throwing light on diagnosis of this pathology, which is attributes to treatment burden in the middle income, especially in the middle income countries, even in larger babies. So she specializes in typically handling these babies in the medical and the surgical management of especially pediatric retinal disorders. If Deepthi is not ready, Madam, can you go ahead with your presentation?
Sure, sure, Arti. Um, I'm just trying to upload here. How do you share screen on this?
That plus button also has a share a screen option, ma'am.
Oh, it's not
Next to
clicking.
audio and video, there is a share screen option.
Yeah, it's not. Oh, yeah.
Ma'am, as you can see, there is a plus sign over.
Yes, yes.
From from there, you can just click on it, ma'am, and you can see the options slides and PDFs. And from that, look, you can upload.
Are you able to see Arti?
I'm able to see you, ma'am. I'm not yet able to see your slides.
I just shared it. Yeah, Arti. Okay, just okay, okay, yeah.
Ma'am, just minimize it and open the PPT, ma'am. Ma'am, minimize it, ma'am. Ma'am, just minimize it and open the PowerPoint, ma'am.
Can you see now?
We are able to see your screen, ma'am.
Can you see my PowerPoint now?
I think it's loading, ma'am. I'll just see. It's completely gone off, ma'am. First, we were able to see your screen.
Uh,
Ma'am, this plus button is there, no, ma'am?
Arti, what's happening?
So we are just, madam is just trying to upload her slides.
No, no. What you should do is ask Supriya. Where is she online there?
She's online, sir.
Ah, it is there
Deepti.
now. Deepti has come. Yeah,
Yes.
Deepti can start. Ask them to open the PPT and keep it on the desktop.
Yes, sir.
Okay, and then go in and press the plus this thing. Ask Supriya to do that. Deepti can
Okay, sir.
start now. Deepti can get start now.
Yeah, shall I start, sir?
Yes.
Okay, good evening, everyone. Today I'll be talking about diabetic retinopathy, pathophysiology, and clinical features. So, as we all know, diabetes mellitus causes several a variety of range of diseases to the eye, not just to the eye, to the entire body. And diabetic retinopathy is the most common microvascular complication of diabetic retinopathy, and it also causes the maximum number of population affecting maximum population of the world in for visual loss. Uh, what is diabetic retinopathy? It is a microangiopathy in the retinal capillaries, shares similarities with the microvascular alterations in kidneys and the peripheral nerves. Clinical manifestations of disease are retinal vascular changes, involves progressive intraretinal microvascular alterations. In type 1 diabetics, about 77% end up with diabetic retinopathy, whereas in type 2, about 25% end up with diabetic retinopathy, of which 25 to 30% end up with vision threatening diabetic retinopathy, 8% require laser photoablation, and 5% require vitrectomy. The risk factors, the duration of diabetic retinopathy is a very important risk factor where 99% patients with type 1 diabetes and 60% of patients with type 2 diabetes have some form of diabetic retinopathy after 20 years. Glycemic control, a good blood sugar control can delay or prevent the diabetic retinopathy. Modifiable risk factors are hypertension, dyslipidemia, anemia, nephropathy, and smoking, whereas non modifiable risk factors include age, male gender, puberty, pregnancy, genetics, and duration of disease. The genetic basis of diabetic retinopathy, risks of diabetic retinopathy emergence is 3 times higher for patients with a family history of diabetic retinopathy. Twin Studies has reported diabetic retinopathy concordance of 68% in type 1 diabetes mellitus and 95% in type 2 diabetes mellitus. Heritability score increases with the severity of diabetic retinopathy and has been estimated to be 18 and 52% of diabetic retinopathy and proliferative diabetic retinopathy, respectively. Puberty is a very important risk factor for type 1 diabetes mellitus. Progression of diabetic retinopathy is quite rapid in post-pubertal years. Pregnancy, diabetic retinopathy, and diabetic macular edema progress in pregnancy and regresses in postpartum without any long-term consequences. So let's move on to pathophysiology of diabetic retinopathy. The most critical factor in development and progression of diabetic retinopathy is chronic hyperglycemia. It affects several pathways. Hyperglycemia induced causing hyperglycemia induced damage. So glucose is reduced to sorbitol in presence of aldose reductase. So now sorbitol causes osmotic cell death, osmotic damage, and cell death. Now, sorbitol changing to converting to fructose releases a reactive oxygen species. All these inflammatory signals lead to retinopathy, nephropathy, and neuropathy. Now, a variety of cycles cause advanced glycation end products which accumulate and further cause the oxidative stress. Chronic hyperglycemia also activates a protein kinase C, which sets off the reaction of oxidative stress. Now, this is a slide showing all the pathways in short. So, polyol pathway, hexasimine pathway, and AGE's accumulation and protein kinase C pathway, all leading to oxidative stress, increase the VEGF and increases the neovascularization, vascular permeability, and the breakdown of blood retinal barrier, thus causing retinopathy. Pericytes, which are seen on the blood vessels,
We can say it as a hallmark of early diabetic retinopathy. Thickening of capillary basement membrane, capillary endothelial cell damage, RBCs, deformation and Rolio formation, increased stickiness of platelets, all these cause microvascular occlusion, further leading to retinal ischemia and causing capillary leakage, microaneurysms, hemorrhage, retinal edema, hard X-rays, arteriovenous shunts or irmas, and neovascularization. Now, hypoxia upregulates the VEGF along with hyperglycemia, AGEs, pro-inflammatory cytokines, and growth factors. This causes blood retinal barrier breakdown, leading to diabetic macular edema. Neovascularization or angiogenesis leads to proliferative diabetic retinopathy. Moving on to the classification of diabetic retinopathy given by ETDRS classification, which is the early treatment diabetic retinopathy study, International Clinical Disease Severity Scale for diabetic retinopathy. Now, ETDRS is based on 7 charts with 30-degree stereo images. International Clinical Disease Severity Scale for diabetic retinopathy has been proposed to facilitate communication between caregivers, and it is a simplified classification of non-proliferative diabetic retinopathy (NPDR) and proliferative diabetic retinopathy (PDR). Now, NPDR is characterized by microaneurysms, hemorrhages, superficial, deep, irmas, intraretinal microvascular abnormalities, cotton wool spots. The presence of these lesions in varying degrees determines the mild, moderate, severe, or very severe. Now, coming to the features, microaneurysms. This is the first clinical sign of diabetic retinopathy, and the size could vary from 25 to 100 micrometers. They appear as hypofluorescent foci in fluorescein angiography. The leakage indicates activity. Superficial retinal hemorrhages are located in retinal nerve fiber layer, typically have a thin elongated shape, feather, flame, splinter, or brush stroke in appearance. And deep retinal hemorrhages or dot blot hemorrhages found within the inner nuclear or outer plexiform layers of the retina. They appear slightly darker red than other hemorrhages. Hard X-rays are sharply demarcated yellow-white deposits within the retina, distributed at the border between edematous and non-edematous retina, association with macular thickening and edema. Cotton wool spots, nerve fiber layer infarctions from occlusions of precapillary arterioles bordered by microaneurysms and vascular hyperpermeability. These are small yellow-white or grayish-white slightly elevated lesions which look like clouds with a fimbriate border in the superficial retina. Dilatation, beading, looping, and arterial narrowing are the vascular changes very commonly seen. Now, coming to IRMA, these are the shunt vessels, abnormal branching of the or dilatation of existing blood vessels, capillaries within the retina that act to supply areas of non-perfusion in diabetic retinopathy. They represent either new vessel growth within the retina or remodeling of pre-existing vessels through endothelial cell proliferation stimulated by hypoxia, bordering areas of capillary non-perfusion. This is the ETDRS classification where no DR, no diabetic retinopathy, very mild is microaneurysms only, mild is any or all of microaneurysms, retinal hemorrhages, exudates, and cotton wool spots. Moderate is severe retinal hemorrhages in 1 to 3 quadrants or mild IRMA, significant venous bleeding in no more than 1 quadrant, cotton wool spots. Severe is the 4 to 1, it follows the 4 to 1 rule where severe retinal hemorrhages in all 4 quadrants, significant venous bleeding in more than 2 quadrants, moderate IRMA in more than 1 quadrant, very severe more than 2 or equivalent to 2 of the criteria for severe NPDR. This is the fundus photo of no diabetic retinopathy, very mild with microaneurysms, mild NPDR. This is the moderate NPDR with cotton wool spots, severe NPDR with IRMAs, cotton wool spots, and hemorrhages. Now, proliferative diabetic retinopathy. It is characterized by neovascularization of disc and elsewhere, tractional retinal detachment, vitreous hemorrhage, pre-retinal and subhyaloid hemorrhage, combined retinal detachment, and neovascularization of iris. The ETDRS classification is as follows: mild to moderate, new vessels on the disc NVD less than one third of the disc area, new vessels elsewhere less than half of disc area. High risk includes NVD more than one third of disc area, any NVD with vitreous or pre-retinal hemorrhage, NVE more than half of disc area with vitreous or pre-retinal hemorrhage, advanced diabetic eye disease, which includes pre-retinal and or intragel hemorrhage, tractional retinal detachment, tractional retinoschisis, and iris neovascularization. This is the NVD. These are the examples of NVE. Now moving on to advanced diabetic eye disease. These are the pictures, some of the pictures showing vitreous and subhyalate hemorrhage, tractional retinal detachments with fibrovascular proliferation, and this is the neovascularization of iris, which might further lead to neovascular glaucoma, which is seen in severe ischemia. Now, diabetic macular edema. So, this is seen because of the as the integrity of blood retinal barrier is broken. Now, these are the OCT images of DME. Now, DME can be broadly classified into non-central involved diabetic macular edema and central involved diabetic macular edema. This is the fundus of angiography pictures showing diffuse leakages and macular ischemia showing distorted FAZ zone. What is clinically significant macular edema or CSME? Retina thickening at or within 500 micrometers of the center of the macula, hard X-rays at or within 500 micrometers of the center of the macula if associated with adjacent retinal thickening, a zone or zones of retinal thickening one disc area in size, at least part of which is within one disc diameter of the center of the macula. Vision or sight-threatening diabetic retinopathy is severe NPDR, PDR, and diabetic macular edema. In type 1, the recommended time of first examination is 3 to 5 years after diagnosis, followed by yearly reviews. And in type 2 is at the time of diagnosis, followed by yearly reviews. And prior to pregnancy, type 1 or type 2, prior to conception and early in the first trimester. No retinopathy to mild moderate NPDR every 3 to 12 months. Severe NPDR or worse every 1 to 3 months. Common symptoms include defective vision, central blurring of vision, irritation, redness, discomfort, floaters, cobwebs in front of the eyes, and sudden painless loss of vision. Ophthalmic evaluation of a patient with diabetic retinopathy involves BCVA, intraocular pressure, anterior segment evaluation, dilated retinal evaluation, coherence, optical coherence tomography. Now, retinal evaluation can be done with direct or indirect ophthalmoscopy and slit lamp biomicroscopy using a 90D lens. The special investigations include fundus fluorescein angiography, optical coherence tomography angiography, and ultrasound B scan. OCT in diabetic macular edema helps in assessment of macula and fovea. It helps with diagnosis of macular edema, aids in diagnosing, treating, and monitoring the response. It helps us to decide the course of treatment, lasers and intravitreal injections. These are the some of OCT images, ERM with traction and tractional retinal detachment. And biomarkers are important in OCT diagnosis, which includes hyperreflective dots, drill or disorganization of inner layers, integrity of ellipsoid zone, ELM, external limiting membrane, or vitreomacular interface disorders. What are the indications of FFA in diabetic retinopathy? To investigate poor baseline visual acuity or FAZ characterization, severe or very severe NPDR, asymmetric DR, featureless retinopathy, asteroid hyalosis, multiple coexisting retinal pathologies to identify treatable microaneurysms for focal laser. B scan, fundus assessment in the presence of media opacities, vitreous hemorrhages, and dense cataracts. OCT angiography in diabetic retinopathy is a non-invasive dye-less angiography assessment of FZ, capillary plexus of the retina, changes in diabetics without retinopathy. Now, diabetic retinopathy need not always be symmetrical. It could be asymmetric. Proliferative diabetic retinopathy in one eye and non-proliferative, pre-proliferative background or no DR in the other eye lasting for at least 2 years. This is the example of asymmetric where one eye is showing NPDR and the other eye PDR. Asymmetric diabetic retinopathy progresses. These are the reasons which cause the progression, which includes carotid occlusion after diabetic retinopathy, ocular ischemic syndrome, uveitis or intraocular inflammation, cataract surgery. Now, these causes offer protection, carotid occlusion before DR, Fuchs heterochromic iridocyclitis, posterior vitreous detachment, high myopia, retinitis pigmentosa, vitrectomy, and glaucoma. Now, what is featureless retina? It is extensive and progressive capillary closure and closure macular ischemia, underestimates the severity of diabetic retinopathy, associated with extraretinal neovascularization and macular ischemia. More than 85% of patients require PRP. Fluorescein angiogram helps us to clinch diagnosis, separate entity from ocular ischemic syndrome. Now, this is an example of it. Diabetic retinopathy does not always occur in the posterior pole, it can also occur in the peripheral lesions. Now, these are the examples from this photo showing. Quickly about gestational diabetes, pre-existing diabetes mellitus. If no DR, first examination during first antenatal visit. If normal, then second examination at 28 weeks. If abnormal, further examination will depend on the stage of retinopathy presence or absence of DME. Pre-existing DR, then it treat and follow up according to the pre-existing pathology. How do we prevent diabetic retinopathy? The management of diabetes and associated other systemic conditions, patient education, self regulation of diabetes mellitus, and active lifestyle is very important. Management of diabetic retinopathy requires a multidisciplinary approach, adequate control of all baseline systemic parameters. A regular follow up with ophthalmologist is a must. Now, diabetic retinopathy causing proliferative diabetic retinopathy, the first line of treatment is pan-retinal photocoagulation. In advanced diabetic disease, one can consider pars plana vitrectomy. In diabetic macular edema, the first line of treatment is intraocular injections of anti-VEGFs and steroid injections if it is center involving diabetic macular edema. In non-center involving, one can consider focal macular laser. What are the take home points? Progressive microangiopathy culminating in blindness. Routine examination can help detect sight threatening complications early. Good glycemic control goes a very long way, and metabolic memory should not be ignored. Thank you.
Thank you, Dr. Deepthi, for extensively covering on diabetic retinopathy. So that was a very detailed talk. We can have the discussion towards the end of the session. I now invite Dr. Supriya ma'am, our HOD of VR surgery and chief vitreoretinal surgeon, to go ahead with the presentation.
We take the questions later, Aarti, discussion later.
Yes, sir. We'll, because of want of time, we want to discuss towards the end, sir.
Fine, fine, no problem. Supriya is giving a talk now.
Yes,
Yes,
sir.
sir.
Thank
Can you
you.
see my slides, Aarti?
Not yet, ma'am. This is mine, ma'am. I'll just delete it off.
Can you see now? Hello?
Sorry,
No,
not
ma'am.
yet, ma'am.
It's open on my screen. It's open on my screen, Aarti.
Okay, ma'am. Here, it's not. Deepti's is coming now, ma'am.
Deepti, can you stop sharing then?
I'm not sharing it actually. One, just a second.
Just delete your
Yeah, I've
presentation
removed
from
it.
the top. Ah.
Yes, I've done that.
Till Madam is uploading, if there are any questions, we'd like to take it. If anyone is online, to Dr. Deepthi regarding diabetic retinopathy, when will you recommend a patient to be referred to an ophthalmologist? When should a patient refer a patient with type 1 or type 2 diabetes mellitus to an ophthalmologist? At what time point?
So, in type 1 diabetics, like I have just mentioned, about 4 to 5 years later, or in patients who are post pubertal as the retinopathy progresses quite rapidly. And in patient in type 2 diabetes, as soon as they are diagnosed with type 2, yes, they can be referred to the ophthalmologist for screening of diabetic retinopathy.
When you refer to a physician, like what are the parameters do you expect to assess, and what are the other systemic parameters which have an impact over diabetic retinopathy? Like any
Yeah,
insight to that?
yes. Glycated hemoglobin assessment, the 3 month accumulated, blood sugar levels, HbA1c is quite important. So, and apart from the fasting and postprandial, and hypertension is also known to cause is also known to impact diabetic retinopathy. So, we should also monitor hypertensive as well, hypertension values as well, if it is under control or not. And cholesterol levels profile is equally important.
Arti, can you see my screen now?
No, no,
No,
we're
ma'am.
not able to see.
Any impact of renal diseases on pre-existing retinopathy?
Any impact of?
Renal
Yes,
derangement in renal parameters. How do you
yes,
think it affects?
yes, it
Ma'am, we are
does. It does affect, and it does cause the progression of diabetic retinopathy. So that should always be kept in mind and ruled out.
Ma'am, we
We'll
are
have a
able to see.
very nice talk, Deepthi.
Thank you,
Very
sir.
nice talk. I think it was a very comprehensive talk, I thought. But
Yeah,
more
thank you, sir.
importantly, the message which is very necessary, especially in a webinar like this, wherein even common people are also there here, we need
Hmm.
to tell them that diabetic retinopathy is a systemic disease. So
Yes,
please understand this very clearly, and whatever we treat is only the tip of the iceberg. So the
yes,
entire iceberg is there, and we have to make sure sensitize the physicians, the other doctors, other ophthalmologists, the general public about the diabetic retinopathy, and that's why AOS has taken up a very major program, major drive to screen every diabetic in this country. Close to about 100 million people are diabetic in this country now, and we are planning to screen almost everybody. And to make sure that, because if you have 100 million people, 20 million people are likely to develop diabetic retinopathy in the future. So I think it's very important. I think Supriya's talk is ready.
Yes, sir. Can you see my slides?
No.
ma'am. We briefly saw the slide and then it disappeared.
Yeah, we came. The slides came and went.
Now?
Yes,
Ah, yes.
Okay. Okay.
Fine.
So my talk is about screening of prematures, retinopathy of prematurity. Earlier on, the neonatologists and the pediatricians, their main aim was to try and save the life of these very small babies, the preterm babies born less than 34 weeks, 20, even late 20 weeks and all. It used to be a struggle to keep them alive. Now that there's been significant improvement in the neonatology care, the technology that helps them keep these babies alive, the equipment and the expertise, then now ROP, which is retinopathy of prematurity, has become a third epidemic for us. The first being diabetic retinopathy, glaucoma, followed by retinopathy of prematurity in these, and it's a cause for reversible blindness. Now, what is ROP? It's a fibrovascular proliferative disorder of the developing peripheral retina in premature babies. So, what happens in term babies is the retina is completely vascularized here at birth, but in preterm babies, they're born much before the retina is able to completely vascularize, and hence the blood vessels don't reach the edge of the retina. And what happens when we give them supplemental oxygen? These preterm babies, when they get excessive oxygen, it causes hyperoxia, that is vasoconstriction of these immature vessels. If there's vasoconstriction, leads to retinal hypoxia, that leads to excessive VEGF formation, and that leads to abnormal neovascularization. So there are three phases. Initially, in premature birth, all these maternal derived growth factors decrease, so hence supplemental oxygen is given. This leads to vasoobliteration, which leads to increase in these free radicals and lipid perioxidation. And that hypoxia now leads to increase in metabolism and abnormal blood vessels or neovascularization. This usually develops at the border of the vascular and the avascular retina. The risk factors for ROP is primarily prematurity itself. The other risk factors are low birth weight, high exposure to oxygen, prolonged exposure to oxygen, apnea, sepsis, anemia, cardiac defects, multiple blood transfusions, and respiratory distress syndrome. Now, who are the babies that we screen for ROP? Those with birth weight of less than 2,000 grams, a period of gestation being less than 34 weeks, who've had prolonged oxygen, or a stormy postnatal period. These are the guidelines given by the Neonatal Foundation, National Neonatal Foundation, and that gives us a list of criteria whom to screen. When do we start screening is 3 to 4 weeks after birth. But in babies who are very small, that is less than 1200 grams or less than 28 weeks, we come in earlier. That is 2 weeks at least. Within 2 weeks, we screen these babies. The first examination should be before 30 days of life. And if the baby is going dama, sometimes what happens in they spend a lot of money on the ventilator, they end up spending a lot of money in the NICU, and then they want to switch hospitals or they just want to take the baby away. So you have a lot of babies who go on discharge against medical advice. You owe that baby at least one screening before the baby is discharged. When should you stop screening is when the blood vessels reach the periphery of the retina or the ora serrata. That's full retinal vascularization, which takes 40 to 45 weeks post-menstrual age, or you see regression of ROP. What are the myths associated with this disease? Some people think, oh, I have not given this baby supplemental oxygen, hence no ROP can occur. That's a huge myth. There are other risk factors that we spoke about, and 20% of these babies can have other postnatal issues. Another myth is first screening is only at 30 days. Why do it earlier? But we have seen that in smaller babies, in very low birth weight babies, or those born less than 28 weeks, you have to screen earlier because ROP develops much earlier in these babies, or one screening before DAMA. Oh, it's a full term. It does not need screening. No, we have seen ROP can occur in full term and near full term infants, and this can potentially lead to permanent visual impairment. We've seen risk factors such as RDS, multiple birth weights, low birth weight, regardless of their gestational age, and hence universal screening should be the norm in the future. The baby is too sick and hence cannot be screened. No baby, never is any baby sick enough to not be screened. We have screened babies inside incubators, we've screened babies on ventilators, so hence a screening can always be done. Unfortunately, in India, every 2 hours, 3 infants reach the threshold for treatment in India. This is data given by the NICU incidence uh, uh, in an earlier paper published. This is how a premature baby looks when the retina is completely vascularized. It's reaching the ora from the optic disc, optic nerve, all the way to the periphery of the retina. For easier conversing between different scientists across different retina specialists across the globe, there's an international classification of ROP which divides the retina into 3 zones. Zone 1 being the most posterior, zone 2, and then zone 3 as you go anterior, and different stages of ROP. And the ones that we treat will be the most severe diseases. Stage 4 and stage 5 invariably may need surgery. Zone 1 is when there's avascular retina. If you can see, the blood vessels have stopped here, and all this is the avascular retina. Zone 2, this is zone 2 avascular retina, and this is zone 3 avascular, which is only in the periphery. Now, looking at the stages, the first stage of ROP is when it's just avascular and you see an early demarcation line. Here you can see it becoming much thicker, and here you can see fibrovascular bands forming on this bridge, on this ridge between vascular and avascular retina. And here is when traction starts developing, not involving and involving macula, that's stage 4. And stage 5 is when a complete retinal detachment occurs. This is when the retinal, without all the other stages, what you have is an aggressive ROP, where you can see this dilatation, tortuosity, what we call plus disease, happens in the posterior pole. It's a very angry looking retina. Pupils don't dilate well. The media can be hazy. And these are babies who have a very short interval of treatment, a small window, crucial window within which we have to treat these babies. At Rajan Eye Care, we have a retinopathy of prematurity project that we have funded by Rotary. We have a van which takes this camera, handheld camera, and we have a retina specialist going along for screening of these babies. Then after taking the images, we counsel the parents on how the disease is. And it becomes much earlier to counsel the parents when you're showing them photographs instead of just their imagination. You say, this is where the retina, the blood vessels have reached in the retina of your baby, and this is the need for follow-up. You can show them how the retina is developing better, how the ridge is regressing, and even even the NNF guidelines, the RBSK guidelines which are there, insist on pictorial tools during ROP screening. These are the cards. It's almost like an immunization card that the baby goes with, which tells you about all the dates of screening, and at each screening what the picture was in the eye. We leave a note to the neonatologist so that they know what's going on. And what we do is we go to the same center every the same day of the week, every week. Even if there are no babies scheduled that day, we make sure we are there so that there's monotony is good, and there's a schedule which is followed. In case a baby has missed follow-up, they know that every Wednesday we are there in this center, this hospital, and they make sure they're there. Instructions are pasted. All the nurses, specialist nurses are told. These are the hospitals that we've been screening across Chennai. And during follow-up, we kind of call them up the previous day. We have their numbers. These are the babies seen in 2 weeks. Who are the babies? And then we call them up for follow-up. Laser treatment is done for babies who are necessary. We do it bedside, at the hospital itself, at the NICU, or if they're fit enough to come to the base hospital at our center, Tinagar, then they come. Rescue treatment is done in the form of injections in these babies, and you can see how this vascular membrane has grown all over the lens of this is the tunica vasculosa lentis, and hence this may not allow dilatation, and hence early anti-VEGF treatment needs to be given in these babies. And you can see how well the blood vessels post-injection have improved. You can see this ridge, it's formed here, and the vessels are not going beyond this, and after treatment, how well they have regressed. Some babies, despite treatment with anti-VEGFs, they may need supplemental laser, and you can see how well the laser has been taken up here, and the blood vessels are going beyond that. Advantages of anti-VEGF injections are easier, faster administration, reduced refractive errors. Even in hazy, non-dilating pupils, we can give them. The disadvantages, we don't know about the long-term effects, especially neurodevelopmental delay in these babies. All babies need follow-up till the disease is quiet or the blood vessels have reached the periphery. Surgery is required in stage 4, stage 5 babies. And what we do is a sutureless vitrectomy with 25 gauge this system, vitrectomy system. In most cases, we spare the lens so that it doesn't cause any refractive changes in the baby. And you can see how this traction bands are being cut with a vitrectomy cutter. So the aim of vitrectomy here is just to release the traction bands, try and avoid the vascular membranes, try and avoid pulling on any of the retina or causing breaks, and adequate, not a complete vitrectomy, but an adequate vitrectomy is enough. But however, in stage 5 disease, when it's the disease is very anterior, then you don't have a choice and you have to do a lensectomy, vitrectomy, and here forceps and blades and it can be quite tedious and the results may not always be very satisfying, but can give the baby some amount of ambulatory vision. With all these cameras, we need AI is the way to go forward. Artificial intelligence has helped us develop automated detection of these stages of ROP. By feeding enough data into these cameras, we're able to help in deep learning, helps in ridge detection and optic disc detection. So not just the doctors, but even the paramedical staff and the technicians can go and screen these babies and tell us which babies need at who are at risk and need treatment immediately. There are tools which is able to reconstruct these 3D, the raised ridges and help bring these babies for treatment immediately. What diseases have we got other than ROP? We've got congenital diseases like coloboma, cataracts. This is a retinal coloboma. You get septic foci. This is a baby who had septicemia, and we told the pediatricians about the focus in the retina and the choroid, and that baby needed aggressive systemic management. We can pick up tumors early on, like retinoblastoma, and save not just the life of the baby, but also the eye. We can pick up certain conditions like albinism, foveal hypoplasia, and this helps us in training these babies as they grow into children much earlier on. It is not just the pediatricians but it is also the ophthalmologists, and there are a lot of medical legal cases which can cause complications. So it is our duty of both the pediatricians and the ophthalmologists, the retina specialists, to make sure that it's not just the temperature, pulse, but also the eyesight of these babies that we can save. This is the data that we've done. We've screened so far, and the babies treated with laser and anti-VEGF. So our aim is to work towards a world without ROP blindness, as it's a cause of reversible blindness. Thank you so much.
Thank you, ma'am, for that very detailed presentation on ROP. You have included all aspects of ROP, which is started from screening and up to the recent advances, which is artificial intelligence and telescreening in ROP. Ma'am, for the benefit of general physicians and pediatricians, can you speak few words regarding the importance of correction of anemia and thrombocytopenia and premature infants, especially infants with ROP, ma'am?
Yes, Aarti, as you rightly said, most of the diseases that we deal with in the retina are related to systemic status of the baby. So we found out that it's just not, there's enough evidence in literature which supports that there are a lot of causes in these babies. It could be anemia, thrombocytopenia, it could be their other, the birth weight not increasing, getting enough of direct breast milk. These are all the factors that can be corrected, which help in improvement in the vasculature in these babies. So it's a combined effort that we have to make along with the neonatologists in handling these babies.
Yes, ma'am. Thank you, ma'am, for that very elaborate answer. What do you think about telescreening, ma'am, in the future? Do you think telescreening and AI in ROP will be replacing ophthalmologists or IDO examinations in ROP, or you think IDO is the indirect ophthalmoscopy examinations will remain to be the gold standard as it is today?
I think this is like, in diabetic retinopathy, earlier we thought that sending these cameras out in the field will reduce the number of patients coming to the clinic. But no, that's not the case. Our aim with using telescreening, whether it's retinopathy or prematurity, diabetic retinopathy, is to bring the masses that need treatment to the clinic. So we are making sure that no patient slips through the gaps because of non-availability of doctors, non-availability of technology in the semi-rural and the rural areas. Even in urban areas, if they're unable to come to the clinic, we are making sure that we are there at their doorstep to help them with treatment.
Thank you, ma'am. Now I request our chairman and director of Rajan Eye Care Hospital, Professor Dr. Mohan Rajan sir, to speak a few words on the retinal pathologies on this World Retina Day.
I don't have a PPT, but I will tell you something which is very important for all of us and people who are also watching this webinar. First of all, let me compliment Supriya for the wonderful talk on ROP, because ROP is increasing, and it's we can call it the third epidemic, and as far as ROP is concerned, and India is one of the largest countries, largest country with the largest population of ROP babies. So I think it's very important for us to understand this, and because ROP, unlike the diabetic retinopathy, which can be done by general ophthalmologists, the medical retina and other things, ROP can be done only by the retinal specialists who are trained in ROP work. And doing everything is going to be very tough. And it's very important that we have to train more people and diagnose, as Supriya rightly said, diagnose it, sensitize the pediatricians, the physicians, the parents. And what we are doing in the Rotara program, what Shivkumar is doing is something which is unbelievable, wherein he documents everything and explains to the patient. The same model should be replicated across the country, which is very important because this will create an awareness among all the people. And I just wanted to ask Supriya, what is the incidence of ROP in babies who are more than 2000 grams, more than 2 kgs?
So we have published literature by the group from Narayan Netralaya as well
Mm.
as PGI, where they show, and even China shows that it's not only low birth weight, but they're actually seeing in babies who are term babies and bigger babies also. They
Yeah,
found ROP. So I mean, the ideal thing would be the way every baby who's born goes through a screening for metabolic diseases. They always take a tap from the baby, some amount of blood sample, and check for metabolic genetic diseases. They always do an audiometry for these babies before they leave. So similarly, our aim as AIOS should be to let all these babies have a universal eye screening. So at least that we pick up these congenital eye diseases, cataracts, which prevents reversible forms of blindness, that we can detect early and save not just the eye of the baby but the life of the baby also.
absolutely. I think because you had one slide saying that normal term babies do not require screening and all that. But
Yes, sir.
I think all the babies should require screening for ROP, number one. Not only for ROP, but also making sure that the anterior segment is also okay. And also looking for audiogram, everything they are doing that as well. So I think it's a universal high health which is very important, and that's what we should aim for. And only organizations like the AOS can do this across
Yes,
the country, and
yes.
that's why I'm very happy that the AOS will be able to participate in this. And regarding the World Retinal Day or Retina Day, I think retina is very becoming very important cause of blindness in, especially in the third world nations. The reason why, because the increased incidence of diabetes, increased incidence of consanguinity among the parents, and increased incidence of low birth weight infants, and all these are contributing to the retinal conditions. And also myopia, as of now it's about 25-30%. By 2050 it is going to increase to about 50%. So as the myopia is going to, the incidence is going to increase, the incidence of retinal detachments are also going to increase. Please understand this very clearly, that when the myopia is going to increase, the retina is going to become more weaker, the axial length is going to become longer, and all these patients are likely to develop retinal detachment also, despite the fact that we get so incidence. So when the myopia is going to increase, I think we should. It's like a time bomb for us. So all these problems, the retinal problems, are going to come in the future as also. And what was diabetic retinopathy was about 25 million a few years back. Now it has already crossed 100 million. And India is the largest diabetic capital of the world. So on this occasion, I think every diabetic has to be screened. And this is the main aim of the All India Ophthalmology Society. Not only one organization cannot do it. Everybody should pitch in, including all the doctors, all the medical personnel, all the physicians, all the diabetologists, and all the what do you call, the optometrists across the country should pitch in and to aim to screen all the 100 million. More importantly, the awareness among the patients that because of diabetes, in a study which was done about a few years back in Chennai, about 10 years back, and they found out that only 20%, one fifth of the population of Chennai, okay, of a city like Chennai, big city like Chennai, were aware that diabetes can affect the eye. So which means that awareness is very low. So because we find a lot of patients diabetic, Deepthi was mentioning about diabetic, advanced diabetic eye disease, they come with land up in a diabetic stage 4 diabetic. Similarly, we have also patients coming, children coming at stage 5, which means that it is I think the responsibility and the accountability of the ophthalmologists across the country. We shouldn't have, see, coming to stage 4, stage 5 of ROP. I think it's a criminal blunder. We should not allow that to happen. So we should have a robust screening system. Similarly, stage 4, stage 5, stage 3, stage 4 of diabetic retinopathy also we should not allow it to happen. So again, a robust system has to be there. A screening system has to be there for all this. And I think these med talks are very important because it is going across to every section of the society. Very apt on a World Retina Day that we are able to discuss all these problems as well. Another thing is because patients are living longer now, because the lifespan of the average Indian was about 64. Now it has become almost 74. So which means that anybody above the age of 70, 3% is the incidence of age-related macular degeneration. So the age-related ARMD is one of the common causes, becoming very common causes of blindness, loss of central vision, especially the wet ARMD can cause, and repeatedly we need to sing. And aging, smoking, hypertension, these are all the risk factors for wet ARMD, drive to become wet ARMD. So ARMD also we are seeing a lot of numbers. The reason why, because people are living longer, because of the advances in medical technology, because they are able to live longer, and because they live longer, they are able to they are getting all these problems in the eye as well. So again, uh, this is again another important aspect of the retina, which you need to consider in the future also, because more people are going to live longer, and more problems of the retina will also come into play. And of course, we have a big problem which we are not able to solve. This is the hereditary retinal disorders, or the genetic disorders of the retina, wherein because of consanguinity and because of genetic problems, the inheritance, because of that we are not able to see. Again, India, if you take other countries, India is the largest producer of the genetic or inherited retinal disorders. The problem is we don't have proper therapy. There are the gene therapies which are available, stem cell therapy which is available. All these are not proven, and again, it's very costly for an average Indian to do this as well. And there's not a foolproof technique as well. So again, this is another big problem which we need to face in the future, because all these are going to, as the population increases, all these problems are also going to come into play. So we have to focus on the prevention of not only diabetic retinopathy, prevention of diabetes. No, diabetology is talking about prevention of diabetes. How do you prevent diabetes? So lifestyle changes right from the start. When the children, when they sing, they don't give any carbohydrate or anything, no carbohydrate diet, or continue to make sure that uh, the insulin secretion is good good enough, so that lifestyle changes, food food habits. So all these, I think, are relieving the stress, tension, anxiety, because these are all the factors for diabetes mellitus, apart from, of course, the genetic factors which are coming into play. So overall, I think it's a very important thing. The future is going to be completely retina, and because cataract we are able to solve, glaucoma also we are able to solve to a certain extent, and the retina is something which is really bothering us. So I think future is going to be that only. We should focus, and more importantly, we have got 30,000 members of we were members of the All India Ophthalmology Society. There are many people who are not members of the All India Ophthalmology Society. We have to train as many ophthalmologists as possible, if not treatment, but at least for screening and diagnosing, and sending it to the retina specialist at the right time. I think we should sensitize the ophthalmologists across the country, because many of them are practicing in rural areas, and they may not have the facility, don't have the expertise as well, but they should have the facility of screening and diagnosing these people. It's not very difficult with diabetic retinopathy, and referring them at the appropriate time. So this is a message I want to give. Okay.
Thank you, sir, for your detailed insight on retinal diseases on this occasion of World Retina Day. As rightly highlighted, age-related macular degeneration and hereditary retinal diseases pose a significant load, and will become the most significant diseases as the longevity of patients increase. So, as discussed, the retina, being a direct extension of the CNS, serves as a unique window into systemic health. Collaborative efforts between ophthalmologists, physicians, and other specialists will help in the comprehensive management of these retinal diseases as well as the systemic diseases, which will help us preserve vision and optimal health for the patients. So, with this, we'd like to conclude the webinar, and also once again thank IGCP for giving us this opportunity for being on this panel discussion. Thank you.
Thank you very much. Thank you very much, Aarti and Supriya and Deepti.
Thank you.
Yeah, on behalf of MedTalks and IJCP Group, I would like to extend my heartfelt thanks to our esteemed speaker for sharing their valuable knowledge and practical perspectives with us today, and a special thanks as well to all our participants for joining and making this session meaningful. We hope you found this discussion informative and thought provoking. Stay connected with MedTalks for more such academic sessions and knowledge sharing programs. Thank you once again and wish you all wonderful day ahead. Thank you.
Thank you.